Be all right.
Ta-da.
In the UK, some 5 million major operations are carried out every year.
It'll be absolutely fine. We'll take really good care of them.
But some patients' procedures are so complex, only the most skilled surgeons can perform them.
Right, can I start?
Table is locked, we're good.
Nice, please.
Millimetres count. Your focus has to be perfect.
University Hospital Southampton pioneers techniques to treat conditions that few others dare to take on.
This is the sort of operation that you lose sleep over.
So that's the squeaky bum time.
You're always trying to push the boundaries of what's possible.
Every step needs to be done meticulously.
But being at the cutting edge of modern medicine comes with great risk.
This is the tricky bit. Right, let's just get this right.
Sometimes we're a whisker away from failure.
The surgeons bear the ultimate responsibility.
Just worried it's going to crack the bone.
Sometimes it's surgery and things can change just like that.
You are very close to the things you don't want to cut.
If it were to bleed, its entire blood volume within a matter of minutes would bleed out.
Okay, everyone away. Shocking.
I have quite a number of cases that I have never, ever forgotten when something doesn't go well. And that stays with you forever.
It's just not right.
This is what really happens behind the closed doors of their operating theatres.
We've got the lump out.
Excellent work.
You can't really ever let your guard down.
Operation's all done.
It really is the difference between a patient making it through or not.
University Hospital Southampton is one of the largest cardiac centres in the UK and performs around 1,600 heart operations every year. One of its leading consultants is cardiac surgeon Amit Modi.
When I was a junior doctor, I remember seeing a cardiac patient for the first time. I felt the heart for the first time then. And next day I saw the patient in the ICU sipping water, and I felt that was amazing. And that is what I wanted to do every day of my life.
Amit specialises in complex surgery of the aorta, the body's largest blood vessel, which carries over 5 litres of blood from the heart every minute. But his next patient's aorta is threatening to burst. Its thin, diseased walls are bulging and struggling to contain the blood flow's intense pressure.
A normal person's aorta should be 30 to 35 millimeters. On the scan, it's more than 55 millimeters. There's a good possibility that the aorta will continue to become bigger, and at some point it will either rupture or dissect, and that is a deadly situation to be in.
The enlarged aorta has also stretched the valve at the top of the heart, so blood which should flow out is leaking back in.
That is a leak coming back into the heart.
A defect that can cause heart failure.
The aim of this surgery is to prevent catastrophe from happening. Having an annulaged aorta and a leaky heart valve is like a time bomb.
Right, is it in here, is it?
Amit's patient is 70-year-old widow and grandmother, Janette, who's come to hospital with her son.
Do you want a cuddly toy? Morale booster.
My family's very important. I've got a son, Neil, and a daughter, Samantha. Both good kids. I'm very close with my grandchildren. So, yeah, very important to me they are.
Janette first realised how serious the condition was after a heart scan at her local hospital.
I was told we're not happy with the results. We need you to go to Southampton Hospital, but you can't drive. We're taking you in an ambulance. And I think that was the moment I thought, oh.
The diagnosis of a life-threatening disorder has cast a shadow over Janette's life.
You good? I think Mum puts on a brave face about it all.
quite stoic, really. She'll just crack on. She's not one to moan or make any dramas.
Right, have you lost?
Right, take it in. Have you lost? You have no idea when or if anything drastic could happen. I could walk out of this room and drop dead. Nothing will change until I've had the operation.
Aortic work is always complex. It's going to be a long operation.
The aorta is the body's largest artery, which carries oxygenated blood from the heart to the entire body. The top of Janette's aorta, where it comes out of the heart and then arches, is enlarged and threatening to burst. But before repairing this section, Amit must first replace Janette's aortic valve. To access it, Amit will need to cut into the aorta carefully, removing the damaged valve, and then stitch in one made of animal tissue, ensuring each stitch is perfect so the seal is watertight. Then he must cut away the enlarged section of aorta and replace it with a synthetic tube called a frozen elephant trunk or FET device. One end will be placed in her descending aorta where it will expand, with the tube sewn in to hold it in place. The other end will be stitched to just above the new valve. Finally, to complete the reconstruction, Amit must join Janette's new aorta to the branches that supply blood to the upper body and brain.
This is not a routine procedure, and the stakes are high. It is a big deal cutting into the heart and into the big blood vessels and making sure that all the joints are watertight, not bleeding, and everything completed within the time that the body can handle.
Just after 8 a.m, and already half of Southampton's 41 operating theatres are in use. In Theatre C, a team of 12, including anaesthetists, technicians, and specialist cardiac nurses, are preparing for Janette's operation.
All right, so the plan is going to be, we're going to replace the valve with a tissue valve.
There's always the unknown, but then it's a case of you either have it done and things improve greatly, or you don't have it done and you're left on a knife edge. Really, there's no choice.
I'm going to pop some monitoring on, and then the doctors are going to pop some lines in, all right?
Her life is in someone else's hands.
Nothing to do now, just a couple of deep breaths and then breathe normally.
You're fully aware that things can happen that don't end positively. So it's constantly on my mind.
Just before we would start the operation, I would generally have 5 minutes or 10 minutes to myself just to recap on everything that I've planned. And that is an absolute duration of focus when I would not like to be disturbed.
Okay then, happy to start.
All right, skin knife please. Starting.
To access Janette's heart, Amit makes a 20-centimetre incision.
Sawing the bone.
And saws through her breastbone.
Thank you. Saw can go.
Now he can cut through surrounding membranes to expose the heart.
Slowly in this area.
Finally, he gets his first view of the front section of Janette's aorta and can see just how dangerously enlarged it is.
It's massive, oh. The aorta looks much bigger than what I was expecting, and I'm relieved that we are here to do this operation. This aorta needs to be replaced.
As well as its expertise in cardiac surgery, University Hospital Southampton is also one of the country's leading centres for spinal surgery. Consultant surgeon Chris Dare has 25 years' experience.
I started from very humble beginnings. I didn't do well in my A-levels and went through other areas of the healthcare setting. So started off as a nurse, then a military nurse, and then went off to medical school and pursued a career as a surgeon from there. It's such a fulfilling career.
Together with long-standing colleague, Surgeon Steve McGillian, they take on some of the hospital's most complex spinal operations.
I was a trainee here at Southampton, and Chris was one of my consultant trainers and mentors, if you like, during that time period. So I've certainly learnt a lot from him over the years. I think all spinal operations, they're all complex in some shape or form because the potential risks or complications can be quite catastrophic for a patient.
I've got some up-to-date imaging.
Their next patient must face those risks, undergoing a 2-day operation which carries the threat of paralysis. The surgery will tackle 2 debilitating conditions. Stenosis, where worn-out discs have collapsed on spinal nerves, and scoliosis, where the spine is curved in the wrong direction.
The ergonomics of the spine make it a bit more difficult for him to stand at all without discomfort. And combine that with the stenosis, you know, he's in a bit of trouble.
The conditions are compressing the patient's spine, trapping nerves, and causing severe pain whenever he walks. Without surgery, his condition will only get worse.
So I've had a long discussion with him about surgery and what that surgery would involve. And after much thought, he's decided that that's the option he would like to take.
My condition's got worse as time's gone on. I could put up with it, sort of standing, stopping and starting, but now it's got really bad.
59-year-old Andy is a retired welder from Southampton. He was born with a spine condition that's got progressively worse over the last 2 decades.
You walk in and the pain gets greater and greater and greater, and in the end you cannot move. Just like someone's got a red hot poker and they're pushing it in your back. You've got to stop.
Walking is now so difficult, he has to use a mobility scooter.
Before my back pain started, I was a very busy person, really. God, I used to work 60 hours a week, 7 days a week. About 6 years ago, I had to sort of say, no, no more's no more. I can't work anymore.
Andy's wife, Angie, recently stopped working to be his full-time carer.
I find it difficult sometimes because he's not the person I married. He's so very different from that.
That's what got really bad.
He feels he's not good enough because he can't be that person anymore. He really beats himself up over it. So, yeah, it's very difficult to watch.
To get Andy his life back, Chris and Steve will operate together. The surgery will take over 20 hours in total and needs to be done across 2 days.
The first bit is going to be with Andy on his back.
Yeah.
And to access these 2 discs here.
On day 1, they will tackle the stenosis to relieve the pressure on the nerves around Andy's spine. First, Chris and Steve need to operate through the abdomen to reach and remove 2 compressed discs and replace them with metal cages, which will add height to the spine and give the nerves more space. Then, because the next 3 discs are blocked by major blood vessels and organs, they will operate through Andy's side. Here, the discs can be removed and replaced with metal cages again, adding more height and space for the spinal nerves, which Chris and Steve must be careful not to damage because they control bowel, bladder, and leg movements.
Obviously, you know, we need to consider the bigger picture because he's lost that natural curvature, which in itself actually causes a lot of back pain and problems for patients.
On the second day in theatre, they'll operate through Andy's back to remove additional bone to create even more space for the nerves. Then add screws and rods to his spine to correct his scoliosis curve.
There are so many risks associated with this operation. I'm going to dismantle and reassemble the spine. Very complex surgery, which, if it doesn't go to plan, could put you into a worse position than you are now. What I want to achieve for Andrew is to relieve him of his pain, get him out of his mobility scooter, and get him walking independently.
Be fine. Absolutely fine. Stop and rest, darling.
Want to lean on me?
No, fine.
Catch your breath. That's it.
Bit nerve-wracking, but
yeah,
get in there.
Yeah.
It's a long old op, though, isn't it?
You know, it's a lot to subject you to, and by staging it over the 2 days, it just gives your body a chance to recover.
Right, yeah.
It's 9 a.m. and in Theatre E, Chris, Steve and a 15-strong specialist team of anaesthetists, a radiographer and scrub nurses are assembling for day one of the 2-day procedure.
One case today to go through the tummy.
The staff anticipate that this isn't going to be your typical normal day, shall we say. Everybody is prepared for worst-case scenario.
Any other issues or concerns?
No.
Are we happy to send?
Yeah.
Yes, please.
Right.
I am going to be very, very nervous going in. I'm assured I'm in capable hands. I'm just going to concentrate on the time ahead and not think about what I'm going through.
Sit up for me.
Yeah.
Are you all right?
Yeah.
Do you have any allergies?
No.
No allergies?
Only needles.
The immediate time before surgery, the patient is asleep and we're carefully positioning the patient on the operating table, and you need to park your emotions. You may have developed a rapport and a relationship with the patient, but that can impede your judgment.
I think this surgery is as big as it gets, to be honest, in spinal surgery. I think there are very few other operations that we do that perhaps pose as much risk as something like this does.
For the first half of today's operation, Chris will lead and Steve will assist.
Gareth, you happy? Yeah.
Because the damaged discs sit at the front of the spine, Chris is approaching them from the abdomen, making a 15-centimetre incision from Andy's navel to the pubic bone. Now he must cut through fat and abdominal muscles to reach his target.
I can just feel underneath this fat there here. So it's always a bit of a fiddle doing this.
But the abdominal approach carries its own risks.
The challenging part of anterior surgery through the tummy, your visibility can be impaired. It's not as though we make a cut in the skin and we're looking straight down at the spine. So it's slightly in the dark, and at that time I can't actually see the blood vessels or the nerves. I know where they are, but I'm getting there gently.
We were expecting it to be not straightforward. He's a big chap.
After moving the bowel to one side, Chris reaches the spine.
Good. Now, I think that's enough of a view. So we're looking straight down on the disc here. So we've got a knife. Let's just remove what we can. Thank you. Yeah.
Chris can now start to remove the discs that have collapsed, pressing on Andy's nerves.
The disc is it's a bit like a poached egg. It has a hard outer layer, so we're sort of cutting into that hard outer layer. So cutting into this space.
If the blade goes in too far and it goes out the back of the spine, then the nerves are there. So if I cut those, there'll be issues with bladder and bowel, issues with walking. Without due care and attention, it is the catastrophe is just around the corner.
All right. Open to you. Give 100.
Giving 100. The line's clear there.
Is the line pressure okay?
Yes.
In Theatre C, surgeon Amit Modi is preparing to replace Janette's enlarged aorta and her aortic valve.
We'll have a look inside.
But in order to operate on these structures, Amit will need to stop Janette's heart and prevent blood passing through it and the aorta.
Let's go on. Stop wasting time.
To do this, Janette's body will be connected to a heart and lung bypass machine, which will take over the job of pumping and oxygenating her blood.
You're going to lose the red radial. Scissors.
One tube goes into the right atrium to take blood from the heart into the bypass machine. Here it's oxygenated and returned to the body via a tube in the right subclavian artery in Janette's shoulder.
Okay. Go on, please.
Thank you. Going on to bypass. Pump is running. Venous line's open.
Have you primed the cardioplegia?
It is.
With Janette now on bypass, Amit can tackle his first major challenge.
I'll deal with aortic valve next. So in order to replace the valve, I will have to stop the heart. And the way I plan to do it is by putting a clamp on the aorta so that there is now no blood flowing into the heart, into the valve. It gives me a bloodless field. Okay, flow down, right down.
Flows down, right down.
Aorta is clamped.
Yep. Down on flow.
The perfusionist, responsible for operating the bypass machine, now uses cardioplegia, a potassium-based solution, to temporarily paralyze the heart.
Trickle, please.
Giving plegia.
Janette's heart is now stopped, but the longer it's inactive, the greater the risk it won't start again when Janette comes off bypass.
The heart's arrested well, yeah? Okay, that's good. All right, let's do this.
To access the aortic valve, which sits at the top of the heart, Amit cuts into the aorta. Amit can now see Janette's aortic valve, which controls the blood flow out of the heart. A healthy valve is about 1 inch in diameter and has 3 small flaps called leaflets. These open to allow blood to leave the heart, then close to stop it flowing back in.
This is prolapsing. Can you see?
Yeah.
But Janette's valve has been distorted by the enlarged aorta it's connected to.
Our old valve looks quite stretched, which means that the leaflets are not coming together. Therefore, the valve is leaking. Let's see.
Amit must carefully cut the leaflets away, leaving enough tissue so the replacement valve can be stitched into the space.
23 RSR Paramount, please. The Edwards. Valve ready? Stitch ready?
If he doesn't stitch perfectly, it will leak, and Janette will leave theatre with the exact same problem she had at the start.
Yes, everything's looking
Pump
fine.
parameters.
Yep.
Trickle, please.
The replacement valve is made from bovine tissue, which Amit stitches so it can parachute into place.
Running plegia.
200 from now.
Amit can't afford even the slightest movement from the heart, so more cardioplegia is needed to keep it absolutely still.
That's your 200 in and off.
All right, there you go.
With all the sutures in, Amit slides in the new valve, so it sits tight against the heart.
Can you cut the ends off, please? Slow down.
Flow is down.
Yep. Right down.
Right down.
Janette's heart has been stopped for nearly an hour. Now Amit must push her body even further to replace the diseased aorta.
Innominate is clamped.
Okay.
To do this, he needs to stop blood flow through the entire aorta and clamp off 3 blood vessels that branch off it in the neck.
All 3 head and neck vessels are clamped.
Okay.
To prevent the lack of blood from damaging Janette's organs, her blood is cooled, lowering her body temperature and slowing her metabolism so the organs need less oxygen. But after 40 minutes without blood, they'll still begin to deteriorate.
So, lower body arrest time starts.
The stopwatch is now running on the bottom right of the perfusionist's monitor.
Suckers up.
Suckers are up.
Head down, please. This is absolutely the moment where I need to focus. I would not be thinking of anything else except for what I need to do. Head down, head down, head down. Scissors.
For surgeons like Amit, knowing how to sew accurately can be the difference between life and death.
This is a skill which is so essential to surgical training and to surgical practice.
But it's not something surgeons are born with. So consultant surgeon Ayman Al-Zatani holds suturing workshops for Southampton's medical students.
The whole idea about any kind of surgery, you break it down into its components, placing the sutures, then tying them down.
And it starts with something simpler than an aortic valve.
Not too ripe, not too hard. You just need to make an incision. The banana is a very easy and available piece of fruit which has a skin and a flesh. You go at a right angle and you can push from the back and it comes from the other side.
Students Lorinda and Gadir use a synthetic thread, one of over 10 different types used in surgery.
When you pull it through, you'll see there's a natural way the suture is holding, yeah?
If they don't learn the 1,000-year-old technique correctly, they could cause fatal leaks and infections.
So suturing is bringing 2 edges together. If you leave them apart, healing may not happen. Right angle, yes, good, good. Don't hold the tip. There's a lot of mysticism about surgery, that it's something which only gifted people can do, and I would argue that surgery can be taught to anybody. That's nice.
Every stitch must be tied off, and this is where Ayman increases the challenge.
Good. She's basically doing her knot with her eyes closed. In surgery, some parts of the body are away from our vision, so when we are working inside a tummy or a chest, it's difficult to see where your hands are. Now it's nice and flat, see? That's better. We train our students to see with their hand.
The students also learn to stitch blood vessels together using rubber tubes.
You can pull both ends and bring the anastomosis down. Pull that through, land it in.
Okay.
Today's session is voluntary for students who have ambitions to become surgeons.
You need to know the relationship between your fingers to each other and to the things in front of you. And those skills are very basic and they can be developed. I see. Okay.
I'm mixed up my...
Instead of the 1 o'clock there, you've done it 5 o'clock,
yes.
Exactly.
It is very daunting. It's very scary to do it on a real-life patient, but I guess more practice makes better surgeons.
Make sure you don't run over your sutures.
It's so much harder than it looks because you have to get your needle in the right position and then change it, and everything is so small, and it's like it feels very hard to do it just with your hands.
For me, the legacy of surgeons is not how many patients you treat, it's how many surgeons you train to do the job. The more you train, your service to humanity extends beyond the ones you treat.
Midday, and most of Southampton's operating theatres are in use.
We are halfway through the most difficult part of the operation.
In Theatre E, Chris is starting to remove the 8mm thick damaged discs from Andy's spine, which are pressing on nerves and causing chronic pain.
Diseased degenerate discs are much more difficult to remove. We have to take it out piecemeal, and we use instruments just to break it down into little bits and winkle all the little bits out from the front of the disc all the way to the back.
So a nice little nibbler here to remove the front part of the disc.
The disc is like crab meat texture, really. It's hard to describe it in any other way. We need to pick all that out of the residual disc space he's got.
Having removed the damaged disc, Chris must now push the vertebra apart to create space for the new metal cage and more room for the nerves.
Put this between the two vertebrae where the disc is. I'm going to push them apart to open up the space so that we can then put a nice size spacer in there. So I'm just going to hammer this into the disc space.
Chris is operating just millimetres away from important nerves that control the bladder, bowel and motor function in the legs.
So I've got to be careful not to go too far.
There are things that go wrong which you know are inevitably going to be irreversible. If I go too deep, then we're into the spinal canal. And we would then get the spinal fluid leaking out and potentially damage the nerves. And you need to be calm. You just have to be calm under pressure. There is no room for panic.
I think we are there. So that's done.
With space between the vertebra where the disc has been removed, Chris can now insert the titanium cages that will add height to the spine.
And now we have the definitive cage packed with a substance called I factor, sort of bone substitute to just encourages the bone to grow through the cage. So it goes in this way.
The bone will eventually grow through the cage, fuse to the vertebra, and give the spine stability.
Yeah.
The cage needs to be carefully fixed with metal screws without damaging nearby vessels.
3 screws, there's 1 going up and 2 going down.
Every step of this operation involves putting things into the abdomen, sharp things, pointy things. At any point, if I were to slip and not have things docked properly, the blood vessels come into the equation and there's danger at every step. You have to be mindful of that all the time.
X-ray there, please. Good. Just feel that snugging the cage up.
After 2 hours of surgery, Chris inserts the second cage, completing his part of today's procedure.
X-ray there. Good.
Very nice.
Good. Good. Yeah.
Handing over the reins halfway through complex spinal surgery is quite a relief.
Yeah.
I've been focused in the zone, concentrating really hard, and now I can hand over the baton.
Right. Okay, on 3, please. 1, 2, 3.
Steve now takes the lead, but to get to the next 3 discs, he'll need to navigate past muscle containing important nerves.
An inch apart.
So monitoring pads are attached to Andy's body to alert when nerves are under threat.
So what we're going to do is flip him so he'll be facing towards the window.
Steve changes Andy's position. He's operating higher up the spine, and major blood vessels block access at the front, so he'll approach through the side of Andy's torso.
Okay, so let's come through. Yeah. Good.
So at this stage, we're just coming through the skin and the subcutaneous fat.
He keeps the incision small, just 4 centimetres, to minimise the assault on Andy's body. So he doesn't damage any nerves. He uses his fingers to carefully and bluntly dissect the fat and muscle.
There's a tough layer here. We're just working our way through. And again, so we're on the posterior blade. We're green. One of the main challenges with minimally invasive surgery is that you're accessing the spine through a very small hole, if you like. And it can be quite challenging, really, to clearly visualize everything that you're doing. We're very much reliant in terms of the neural monitoring, which tells us if we're in close proximity to any of those nerve structures that might be at risk. Top end, green.
A probe will detect nerve activity. A green signal means Steve can progress. But if it's red, an alarm will sound, indicating it's under threat.
Getting a bit of activity on the monitoring now. We're close to nerves of this segment.
Already the nerves are proving a challenge.
Just kind of in the position where we're about to make our incision. So obviously I don't want to cut through the nerve itself. So I'm just trying to move that nerve and hold it out of the way with the retractor. You're looking down through a long, narrow window, and sometimes it can be quite challenging to work out what's what. Nerve fibers may look like a tissue or something else.
That's on the nerve there.
Can you see it directly, Steve?
The nerve?
Yeah.
Yeah. So I know where it is. Picture there? Nerves crossing the surgical field obviously can be a bit of a challenge. You've got to work out how to get that out of the way so it's not going to interfere with the rest of the operation.
Finally, Steve manages to move the nerve out of the way.
And we're just gradually working our way through in terms of clearing out the disc. So again, this disc material coming out. Oops. So you can see that disc space is starting to declare itself quite nicely.
With the damaged discs removed, Steve must replace each of them with metal cages, similar to those used by Chris.
Picture there? That's good. So we're happy with our position. Okay. Right, implant please. Okay.
Steve must be guided by X-rays each time he inserts a metal cage.
Picture there? Good, okay.
We're on the home run.
We're quite happy with our neural monitoring. The background, everything's nice and green. So we'll start off again. Mallet. Picture.
It's good.
After 7 hours in theatre, Steve and Chris have done as much as they can today to relieve the pressure on Andy's nerves.
I think day one went very well. We hope that we've achieved a decompression of some of those nerves. We had a few little challenges along the way, but I think we're very pleased with how it's gone.
In 3 days, they'll operate through Andy's back to create even more space for the nerves, as well as correcting his scoliosis.
Okay, second blow, please.
Okay, I'm just going to change the pleated bottle before I do that.
Second blow.
Late afternoon, and in Theatre C, Surgeon Amit is in the final stage of his operation, replacing Janette's aorta with an artificial graft.
Can I have another clamp, please?
To do this, he stopped blood flowing through the aorta to the lower body, but the longer Janette's organs are without blood, the more likely they could be seriously damaged.
The blue I've clipped the blue.
So he set himself a deadline of just 40 minutes to attach the new aorta and restore the blood flow.
And then let me know every 10 minutes, yeah?
Every 10? Yeah. You're at 14 at the moment.
First, Amit must cut out the ascending aorta and aortic arch, which are damaged and threatening to burst. Then he will place one end of the artificial aorta into Janette's descending aorta, double stitching the base in place. Only then can Amit connect a blood supply from the bypass machine, so blood flows back into the lower body. Next, he must stitch the other end of the artificial aorta to the top of the heart, where the new valve is. He will then restart the heart. Then he'll connect the 3 branches of the graft to the branches of the arteries, which carry blood to the head, neck and arms. Finally, he can let the heart pump blood back around the body.
Forceps. I want to get this part of the operation done in 40 minutes so that I can restart the blood to the lower body. If I were to take longer, it can mean risk to her life.
Amit cuts out the entire section of diseased aorta.
Fred, please.
One end of the polyester graft, known as a FET device, is placed in Janette's descending aorta, where it will expand.
Let me know at 20 now.
Will do.
At this point, I have to make sure that the FET is aligned well with the aorta and the cuff is placed in the right way. I've cut out all the areas which are weak so that I'm not stitching into weak areas.
Before the clock reaches 40 minutes, Amit needs to double stitch the new synthetic aorta in place, so it's watertight. Only then can he resupply blood to the lower body.
Take me around 35, I think.
At 35, okay. We're just at 29 at the moment.
Just have to do this properly. I'm asking Helen for timings, so once I know I've reached 30, I don't want to hear the word 40. That means I've done my job in the right amount of time. Okay, cannula.
It's 35 minutes of cerebral perfusion.
Okay.
With just 2 minutes to spare, Amit has attached the new aorta. Now he can insert a tube from the bypass machine into this section so blood can flow to the lower body.
Second pipe is in, everything up.
The clock is stopped.
Once I've done that connection, you suddenly depressurize and start blood flow to the lower body. So the brain is perfused, the lower body is perfused, and then you relax a little bit.
But now Amit must attach the other end of the synthetic tube to the top of the heart.
I still have lots and lots of work I need to do so that I can put the heart back into the circulation, because we do not want the heart to be stopped longer. You happy with the nerves and everything?
Yeah. 67, 68.
As Amit attaches the new aorta to the heart, each stitch must be placed precisely.
The stitching has to be perfect. If I stitch too deeply, I'm going to catch the electrical fibers. If I stitch very shallow, then there will be leaks. Okay, off.
Off.
Pump off.
Pump is off.
Empty out, clamp is off.
Emptying out. Thank you, clamp is off.
With this end of the synthetic aorta connected, Amit can allow blood to flow back to the heart and wait for it to restart.
Back up.
Janette's heart has started to beat again.
So once the blood starts flowing into the heart will start some form of rhythm. What's the time? 2 o'clock.
After 5 hours of surgery, Amit must still attach the new section of aorta to the 3 arteries that carry blood to the arms and the brain.
Oh, heart is fibrillating.
But Janette's heart has developed an unusual rhythm, known as ventricular fibrillation.
If you want to shock it and see.
Oh, yeah. Ventricular fibrillation is a state of the heart where there's rather a chaotic movement. It just fibrillates, doesn't pump, just does that.
Amit needs to give a controlled electrical shock to Janette's heart and correct its rhythm, or else it won't pump blood around her body.
That shock. Okay, can we shock? Okay, everyone away. Shocking.
Janette's heart has now started to beat normally.
Fibre, please.
Finally, Amit can now attach the remaining branches of the graft to Janette's arteries. With the synthetic graft now connected to every artery, Janette can be taken off bypass, so her heart can pump blood into her new aorta.
Should we come off?
It's the ultimate test of Amit's every stitch.
Okay, come down and off. You happy with your gases, potassium?
I am.
After 6 hours in theatre, Janette's heart is pumping, her new valve is working, and the synthetic aorta is carrying blood to her body.
That's good, off there.
And we're off bypass there.
Venous line is clamped.
Thank you.
And out. Even though I've done over 1,500 cardiac procedures, I still feel how miraculous the heart is. It amazes me every time I do this operation, how I can stop the heart and restart it. That's an amazing feeling. Air is good, valve is good, ventricle is good. Nick, are you happy with everything? No problem?
Absolutely.
Closing. Thank you. So Janette is now going to go to the ICU. We'll keep an eye on everything, exactly. And everything needs to work well.
Janette will now recover for 3 weeks in hospital and return 5 weeks later for a heart scan.
Hopefully, she's not going to have serious complications from the operation. Till we see her in the clinic again, we don't know if her heart is functioning properly.
Three days after his first spinal operation, Andy is heading back to theatre for the final part of his procedure.
We'll see you when you're awake. We'll take very good care of you.
Today, Chris and Steve will be operating through Andy's back. First, to correct the scoliosis curve, Chris and Steve must carefully insert 20 screws into the sides of Andy's vertebra, known as pedicles, avoiding the spinal cord just millimeters away. Any damage could paralyze Andy. Then, metal rods will be threaded through the screw heads and manipulated to straighten the spine. To help ease pressure on Andy's nerves even further, the surgeons will remove sections of lamina, the bony arches in the spinal column, without damaging the dura, the membrane surrounding the spinal cord.
That's our incision. Okay, from there to there.
Because Chris and Steve will operate so close to the spinal cord, neurophysiologist Harry will monitor signals from the nerves to check they aren't being damaged.
The neurophysiologist's main function is to alert us to any changes during the operation in terms of the signals going from the brain to the tips of the fingers and toes and indeed back again.
Just running MEPs.
If we were to damage the nerves, his mobility is already quite poor, and we can make that a lot worse than it is now, rendering him wheelchair dependent for the rest of his life.
MEPs are fine.
Yeah.
We're getting them all at a nice low current.
Okay.
They start by making a 40-centimetre incision from the top of the buttocks up to the middle of the back.
Yeah, this stage of the procedure just takes a little bit of time, really, just dissecting the muscles off to expose the lamina in the back of the spine.
The spine gradually comes into view.
Chris will make holes in the sides of the vertebra, known as pedicles, to insert 5 centimetre long metal screws millimetres away from the spinal cord.
Are you happy if we run a motor before the first screw?
Yeah, sure.
Stimulating? Yeah, that's great, thank you.
These are small corridors of bone that we're going to put a fairly large screw in. And so it's important we put those screws in the right place. There we go.
Gently insert the screw down into the pedicle. If we ram it in really quickly, then there's a risk the pedicle would split. Same again.
After 2 hours, all 20 screws are in place. But the neurophysiologist still has to check if any nerves have been damaged.
So we're just going to do a motor evoke potential. What about muscle contraction?
If Andy's muscles don't twitch, the screws could have injured his nerves.
Motor's all stable.
Very good.
Sensories are stable as well.
Andy's nerves are intact. But the next stage is even riskier. They'll chip away the roof of the spinal canal, called the lamina, which will help relieve pressure on the surrounding nerves. But as they get down to the final sections of lamina, the bone is stuck to the dura, the wafer-thin membrane containing spinal fluid, with nerves running just below.
Just got to be careful here because the ligament underneath sometimes is adherent to your bone.
There we go.
It can be a little bit of a hairy part of the procedure when you're using a hammer and a chisel, if you like, around very sensitive nerve endings.
Silky nibblers.
Often when you've freed up the lamina, then it's almost like peeling a prawn. You can peel away this bone and ligament away from the underlying nerve site.
Removing this bone allows more room for the nerves. Later, a bone graft will fuse to protect it, but right now, it's vulnerable.
If you create a big tear, all the spinal fluid pours out of the spine. The nerves then herniate into the wound. You then expose all the nerves to the blood in the wound, and that can cause the nerves to clump together and stick together. And that can cause long-term neurological problems, creating worse nerve damage than he has already. Then that's actually quite difficult to repair.
So I've just created a plane between this ligament and the dural fat.
Finally, Chris and Steve think they've removed enough lamina to create as much space as possible for the nerves in Andy's spinal column.
So now we're going to start preparing the sort of final stage of this operation by popping the heads on the screws.
Chris and Steve have been operating for 10 hours, but they still need to finish correcting the curve in Andy's spine. Metal rods are bent into shape and placed on clips. The bone that's been removed will be ground down to make a bone graft.
So this is the coffee grinder, putting in the bone chips into here so that we can then use it as bone graft, so patient's own bone.
The graft is spread over Andy's spine to promote new bone to grow.
And then some of the graft is just packed into a syringe with the end cut off. It just acts as a graft delivery system, really.
The bone takes about a year to form a rigid structure, and that will protect the metalwork.
After 2 days and nearly 21 hours in theatre, Chris and Steve have finally finished the entire procedure.
Andrew, hello mate, operation all over.
Although we've relieved the stenosis and freed up the nerves, Andy's had to endure quite a big operation, which doesn't mean he can just jump out of bed, throw away his crutches, pack his bags and go home. This is where rehab starts. That could be a bit of a rocky road. There'll definitely be ups and downs during that journey.
It's been 8 weeks since Janette had her heart operation, and a scan has revealed that her new aorta and valve are working well.
Bit by bit, I'm getting back into a normal routine. I don't have the worry of the aneurysm busting. Can you get the large milk out, please?
She seems to be recovering really well. She's got her independence back, she's got her confidence back, she's happier going out and about, carrying out a normal life. Cheers, Mum. Good that we're getting cakes again.
Janette's operation has gone very well. We've delivered everything that we promised Janette.
As far as the surgeons are concerned, what can you say? I mean, I owe Mr. Modi an awful lot. He's given me my life back.
In cardiac surgery, we have the ability to restart the heart, and the patient does well. And every time we do this, I feel like a sense of achievement.
You'll be all right. Just got to take it slowly, little bit by little bit.
3 months after his surgery, Andy is back at hospital to discuss his latest x-rays with Chris.
So how do you think you're doing?
I think I'm doing okay. I feel like I am getting back to my old self again, I must admit.
I've just put the pre-ops up for comparison. This is the day's x-ray, which shows the 3 lateral cages and the 2 anterior cages. The scoliosis is gone.
What a difference. And to see it like that and how it was like before.
I do want you to be motivated to progress and to engage with the physios and to push yourself, because you do need to push yourself, because it's easy not to do that.
That's right, Been able to walk for a long time.
Walk around the shops, haven't you? For the first time in 12 years?
Yeah.
For the results that we've seen today, he's done exceptionally well. It's a life-transforming event. All right, you take care.
Thank you.
You're happy, though. Good news. Good news.
You turn someone who's become very insular because of their disability, and you have the ability to turn that round. There is nothing more rewarding than having a good outcome.
Next time, major trauma.
Right neck injury, right chest injury.
2 motorcyclists with life-threatening injuries
Drop his pressures. Pull him out.
and emergency surgery
The angle is completely wrong. It's a bit of a fiddle, this.
to save their lives.
The sooner we get him off the table, the better.